Hello, and thank you for joining us for the President's Plenary. I'm Jaya Raj, Acting President, and it is my honor to introduce our plenary speaker, Dr. Nicole Piemonte. Dr. Piemonte is the Assistant Dean for Student Affairs and Associate Professor of Medical Humanities at Creighton University School of Medicine, Phoenix Regional Campus. She holds the Peking-Nash Carpenter Endowed Chair in Medicine at Creighton University as well. Dr. Piemonte received her PhD in Medical Humanities from the University of Texas Medical Branch, where she studied continental philosophy, medical ethics, literature and medicine, and medical pedagogy. Her current teaching and research focus on incorporating the humanities into medical education to cultivate future physicians who are attuned to suffering, mortality, vulnerability, and social justice. At Creighton, she designed and leads the medical humanities curriculum in the School of Medicine, and she also serves as the program director for the Masters of Arts in Medical Humanities program. Dr. Piemonte has published 2 books with the MIT Press. The first, published in 2018, is Afflicted: How Vulnerability Can Heal Medical Education and Practice, and most recently published in 2021, Death and Dying. Once again, it is a pleasure to welcome and thank our speaker, Dr. Nicole Piemonte.
Hello, and I want to thank you for inviting me to be part of the President's Plenary. I am honored to be asked to speak to this group, and it's about a topic that I think is really important, this idea of talking about and acknowledging vulnerability in medicine and how this is related to cultivating compassion among colleagues and in particular among your trainees. So I want to start off today with sharing this quote from Stephen Bergman. So those of you in the room might be more familiar with his pen name, as he is Samuel Shem, the author of House of God. Many of you in this room have read this book, but you might be surprised then that he has said something along these lines, which is how to learn empathy. Try living through suffering with someone, really living through, an opportunity we doctors have every day. I think what Stephen Bergman is pointing out here is that medicine is replete with suffering. It's kind of saturated with the human condition. And those of us who have suffered ourselves or watched others suffer, we know that this can cultivate empathy and compassion. But historically, we have not been very good about talking about suffering in medicine, particular emotional suffering. We don't acknowledge it, and we rarely acknowledge our own suffering and the suffering among our trainees. Indeed, I think that we've only just begun talking about non-physical suffering, emotional or existential suffering among our patients. And the literature around that has really looked like trauma-informed care. And some of you are probably part of clinics or hospital settings in which trauma-informed care has become part of your practice. And really, trauma-informed care shifts the focus on thinking about patients that instead of what's wrong with you, what's happened to you. So what is wrong with a difficult patient, or kind of the problematic term of a non-compliant patient, it shifts it away from what's wrong with this person to what might have happened to this person. In particular, what kind of trauma might they have experienced that leads to them kind of engaging in the world in this way. And trauma-informed care also presupposes that care teams need a complete picture of a patient's situation, their past and their present, their whole life, to understand how to care effectively, and in particular, how to care effectively for a patient who might have a past history of trauma. So what trauma-informed care is doing is it's seeking to do several things, which is to realize that trauma is widespread, that so many of us have experienced trauma, and to understand that there are paths for recovery for patients. trauma-informed care really integrates, kind of bakes in policies and procedures in clinics and in healthcare practices to make sure that trauma is being addressed, to actively avoid re-traumatizing patients. And what's important here is that trauma-informed care tries to recognize the signs and symptoms of trauma in patients and their families. And this is important here. This is also in staff, in colleagues, in our medical students, our residents. Can we recognize when someone might be experiencing trauma? Now, you might be saying to yourself that perhaps you haven't experienced trauma, or in your trainees, maybe they haven't, because what is the definition of trauma? What are we talking about when we talk about trauma? Now, most of the literature around trauma in healthcare defines trauma in this way, that it is a result of exposure to either an incident, an intense incident, a car accident, or an assault, or a series of events that are emotionally disturbing. They might be life-threatening. They've got lasting adverse effects on your functioning, on your mental, physical, social, emotional, spiritual well-being. What's important here, I think, is that emphasis on a series of events. The literature on trauma acknowledges that trauma can result in growing up in a household that might feel chaotic, a parent who might be an alcoholic or suffer from severe mental illness, from living in poverty for an extended period of time, that these events that might not seem like huge cataclysmic tragedies or traumas might indeed be causing trauma among so many of us. Really, when we look at the etymological root of trauma, we see that in the 1690s, it's starting to be used in the medical context, like a physical wound. And we think of this in the trauma bay, or a patient who comes in with trauma. And this is from the Greek word trauma, which is a wound or a hurt. But we apply this to understanding emotional and psychic trauma as well. It's a wound. It's a hurt. It's a pain. And so many of us do share in that pain, even if we are not referring to it as trauma. For instance, when we're looking at what has been happening recently to people who've been living through a pandemic, and in particular clinicians, this came out in the New York Times in late 2021, looking at, we might have been calling it the term burnout, but what we're pushing towards is this idea of languishing. And you'll see in the medical literature, this term about languishing is starting to appear in the burnout literature. And so what is this idea of languishing? According to the author, he says languishing is the neglected middle child of mental health. It's that void between depression and flourishing. It's just this absence of well-being. So you might say, I'm not clinically depressed, but I'm certainly not thriving or flourishing. I'm just not doing well. And it's this sense of stagnation or emptiness, the author says. It feels as if you're muddling through your days, you're looking at your life through a foggy windshield, and it might be the dominant emotion of 2021. And this is more intense, I believe, for healthcare workers, for people like you and your trainees. And it was intensified immensely through COVID and seeing the pain and the trauma, people dying alone and feeling totally out of control. I also believe that our healthcare system, which is broken in so many ways, even without a pandemic, can cause languishing. This emphasis on productivity and efficiency and generating RVUs, which really encourages a disconnection from patients and from why you might have even gone into medicine in the first place, with the focus on the EHR and coding. This can cause languishing. This can cause the kind of deep pain. What the author says, though, is there's some danger in this. Part of the danger with languishing is you might not even notice it. You don't catch yourself slipping slowly into solitude. And the danger is that when you can't see your own suffering, you don't seek help, or you don't do much to even help yourself. I think many of us are in this kind of state of languishing, or even worse, some more intense suffering, I do believe that we're all wounded, even if we can't see that wounding and we don't recognize it. I do want to share with you, this is a really fantastic book. Many of you might have read it. It is a New York Times #1 bestseller by Susan Cain, Bittersweet: How Sorrow and Longing Make Us Whole. And I would recommend this, especially for anybody in medicine like yourself. And she really speaks to the point that there is a danger in not recognizing our own pain. She says, if we don't transform our sorrows and longings, we can end up inflicting them on others via abuse or domination or neglect. And I would say in much subtler forms, we can spill our pain over to patients and colleagues, to trainees, to our partners. The upside of this is that when we do recognize that pain, it can be transformative. She says, if we realize that all humans know or will know loss and suffering, we can turn toward each other. This is echoing a bit of what we see Stephen Bergman talk about in that opening quote, that it's suffering and pain that can teach us empathy and compassion. What's difficult, though, is looking at pain is hard. And we see so much of it in medicine. Arthur Frank is a medical sociologist. He wrote a book after, at the age of 39, he had a heart attack, and the next year he had a cancer diagnosis. And he wrote a book, At the Will of the Body, that talked about his experience of illness. And he's really taking a sociological look at medicine. And what he noticed was that for physicians, sometimes it was hard for them to look at his pain. He says, voices of patients can be hard to hear. They bespeak conditions of embodiment that most of us would rather forget our own vulnerability to. It's hard to look at the fragility and the suffering, the physical suffering of patients, the emotional suffering of patients, because it reminds us of our own vulnerability. So for clinicians, they might turn away from their patients when they see that kind of saturated suffering in one person. But what I've noticed is that when we see others suffering, we not only turn away from that suffering or are tempted to, but we start to turn away from our own suffering, our own woundedness. We don't want to look at our previous traumas, our painful past, things we've been disappointed with. And sometimes patients can be reminders of our own pain. And this can be difficult because it makes compassion a little bit more difficult to really cultivate when we're afraid to look at that pain. So Martha Nussbaum, a very famous moral philosopher, love this picture of her from the New Yorker. She talks about compassion in her book, Cultivating Humanity. She says, compassion requires a sense of my own vulnerability to misfortune. To respond with compassion, I must be willing to entertain the thought that this suffering person might be me, that this patient in the bed before me could be me at any moment. That compassion requires me to acknowledge that. She goes on to say, I'm not going to be likely to do this, right? This is unlikely for me to do if I'm convinced I'm above the ordinary lot and no ill can befall me. Now, there are many of us who know and have seen suffering, and we know that suffering is a part of our lives, but often I see with my own medical students and sometimes with my residents, this unwillingness to acknowledge that I am suffering, this separation between student doctor or doctor and patient, this idea that the patient is suffering and I'm the healer, I'm impervious to this, I won't be sick and suffering and potentially dying in the same way. That makes compassion difficult because compassion requires humility and compassion requires vulnerability, acknowledging that I suffer too. If we look at the etymological root of compassion, we see something really interesting. So one of the root words here in compassion is passion, the suffering of pain. We see this with the term, the passion of the Christ, right? Like the suffering of pain, emotional and physical. And then we see com, which is in combination or in union together. So quite literally, the word compassion means the suffering of pain together. Not that my compassion is that I can see you over there suffering, but it's I suffer too. I can tap into my own pain, and your pain is a reminder of that. Joanna Shapiro is a medical educator of over 30 years, and she's also a psychologist. And she writes that without acknowledging their shared mortality, frailty, and vulnerability, students will not be able to make much sense of truly caring for others. She sees that her medical students will have a hard time caring well for patients who are suffering if they can't acknowledge their own shared suffering and fragility. So in my view, then, compassion is not really a skill that we can teach. It's not something to be learned. It's more of a way of being. It's this ability to recognize our own potential for suffering, for illness, for injury, our own fragility. That's where compassion starts. And that's why compassion is hard. And that's why compassion is scary, because it requires a hard look at myself. This is why I think we see these ideas about professional distance. This idea that students or residents or clinicians need to have a sense of detachment, some objectivity, compartmentalizing emotions to protect ourselves from feeling too much. And this is an understandable approach. I don't want to feel that intensity of pain or suffering. And so I'll maintain this professional distance. But it turns out this doesn't often work very well. So Stanford psychiatrist Dr. Anna Lemke, she's actually the author of Dopamine Nation, which was also a best-selling book and really worth the read. She's looking at the crisis of addiction in our country, and she really points out that it's not just patients who struggle with addiction or with suffering or with pain, but also clinicians. She says, our patients can see through us. We bring ourselves to the practice. I think it's helpful for patients to know we are all broken and we all struggle. She goes on to say, doctors are all the same regular people with all the same regular problems, but the shame can be more pronounced because you're supposed to be this healer who's got it all together. And so when we don't recognize our own brokenness, therein lies the temptation to maintain a distance and a disconnection from patients. So our own pain, our own unprocessed trauma can cause us to compartmentalize and dissociate and depersonalize. And what is the result? The result is disconnection, it's isolation, it's that languishing, it's burnout, just going through the motions. Ironically, trying to protect ourselves from pain intensifies pain and isolation, because we need that connection. We need to be vulnerable. I bet it's safe to say all of us know Brené Brown, but she says something really important here. She's a scholar who's studying vulnerability, and she says, of all the things trauma takes away from us, the worst is our willingness or even our ability to be vulnerable. We can't be vulnerable when we've had so much trauma. She said there's a reclaiming that has to happen. So what does that mean? What does it mean to reclaim vulnerability? Well, let's review for just a moment. Trauma, as we learned, means a wounding. And when we look at vulnerability, when we look at vulnerable, we see this is also from the Latin, and it means wounding. Trauma is wounding, and vulnerability is wounding. So in some ways, we have to let ourselves be wounded again in order to be vulnerable. So what does this mean? I can provide an example from my own life where I feel that I've learned this. When I was 20, I took care of my mom who was dying of ovarian cancer, and she died when I was 23. And only a few years later, my dad was diagnosed with gastric cancer, and I took care of him until he died. And those moments were undoubtedly so deeply wounding. And maybe I thought I was being vulnerable, but I wasn't. During that time, I just became more productive and functional and continued to go to school and get a PhD and spin my wheels. and I was avoiding pain. I wasn't being vulnerable. It wasn't until years later when I began to process the trauma of that loss, to genuinely grieve, to let myself be wounded again. Did I start to become truly vulnerable? Did I start to understand the suffering of others? To have that genuine compassion, I had to let myself be wounded again and to become vulnerable. So if it's true that compassion requires this vulnerability, can we cultivate this within ourselves, within our trainees? Can we encourage this? In other words, can we be safely wounded so that we can better see the wounds of others? Something that I think is required in medicine. How do we do this? If we go back to that article on languishing, the author says, by acknowledging that so many of us are languishing, we can start giving voice to quiet despair and lighting a path out of the void. If we can start talking about it, that we are languishing and suffering, we can move toward a path out of it. But it turns out we are really bad at helping medical professionals and our trainees and our students talk about their shared brokenness. Now, I try to talk about it a bit with my students, maybe much to their chagrin, but this is not commonplace in medical education. In fact, an article came out a few years in the Atlantic, and the author quotes that while medical schools may include lessons on things like listening skills and fostering trust, tacitly, students are learning to value objectivity, detachment, wariness, and a distrust of emotions. Not getting more comfortable with their emotions, not being more vulnerable, but distrusting emotions. And we've got professionalism curricula, right? But professionalism is not the same thing as compassion, and it is nothing like vulnerability. In fact, sometimes professionalism starts to feel more like a separation. I'm the professional, you are the patient. And so we're not doing well with cultivating this among our trainees. So that's why I think we have to, as faculty, intentionally model vulnerability, intentionally model connection for our trainees. So how do we do this? Now, you might disagree with me, but I do not think it is through patient-centered care. I don't. I think we need to reorient our focus toward relationship-centered care. Patient-centered care can kind of see things as one-sided, and I want us to acknowledge that clinicians are affected by taking care of patients so much, yet we rarely talk about it. So in relationship-centered care, which is in the literature, it acknowledges that the practice of medicine is interpersonal through and through. It is relational. And relationships matter. The physician-patient relationship, patient-physician relationship, of course, a patient-family, physician-physician, physician-trainee, all of these relationships, they matter. And relationship-centered care has 4 principles. That personhood matters, the personhood of patients and their families, but also the personhood of the clinicians and the people taking care of patients and their families. That affect and emotion are important. They are not something to compartmentalize. That relationships don't occur in isolation. There is context, there is history, and that maintaining relationships is necessary for health. It's necessary for recovery, and it's morally valuable. We should celebrate these relationships and press into them rather than seeing them as unilateral. Dr. Rita Sharon, who started the narrative medicine movement, she says that through authentic engagement with their patients, physicians can cultivate affirmation of human strength, acceptance of human weakness, familiarity with suffering, and a capacity to forgive and be forgiven. I don't know about you, but I don't think we are often telling our trainees that you will learn about forgiveness in medicine when you take care of patients, that you will learn about suffering and what it means to be human. I think we need to acknowledge that, and this is why I'm troubled sometimes by our emphasis on altruism. We see that term altruism in our honor codes, in our mission statements at hospitals, and our training programs, but altruism supposes that the physician ought to be selfless, which is true. They shouldn't be out for personal gain, but it covers over the fact that the physician receives so much from their patients in return. receives the ability to see suffering and recognize one's own suffering, gets the opportunity to see resiliency and also pain and suffering, to learn about forgiveness. And so there's a mutual giving and receiving that comes through genuine relationship-centered care, and that comes with connection. I want to give you another example of this. This is a video that I recently sent out to all my medical students. September is Suicide Awareness Month, and this is a TED Talk with a practicing physician who talks about his time in medical school where he struggled with depression and anxiety and even thoughts of suicide. And so he looked into the literature of why people start to have suicidal ideation. And of course, he found that physicians die by suicide at a rate that's higher than any other profession in the United States. We're all aware of that. And during his reading and research, he came across work that talked about the relationship between feelings of disconnection and thoughts of suicide. That when people start to feel disconnected from others and what matters most to them, there's an increase in suicidal ideation. And this made him especially nervous because, as he points out, disconnecting yourself is a defense mechanism that we use in medicine to deal with the horrible things that happen to people. He says disconnection happens when you want to study so much in medical school or residency that you disconnect from family and friends, or the emotional disconnection you have to do to even be able to cut into a donor body in the anatomy lab. It says disconnection is just normalized in medicine, and it's something that frightened him. So he said it wasn't until the moment that he connected with a standardized patient, no less, in the Breaking Bad News simulation, when he really felt connected to this patient, that afterwards she said, "I hope I never have to get that news in real life, but if I do, I hope it comes from someone like you, because I felt like you saw me." And he said that's when he realized that the antidote to the pain and disconnection he was feeling was to connect to patients. So he says, "I became connected by taking care of people instead of diseases, and I do that every single day of my life now." He goes on to say that empathy is the most important skill any physician or medical student can have. It keeps you human. It keeps you connected to other people. So it is the irony of connecting to the painful stuff, connecting to the hard stuff, that is the antidote to the suffering that he was experiencing. So what are some practical ways that we can get more of this connection, more vulnerability in medicine and in medical training? I'll give you an example of Schwartz rounds, which is something we started at our own hospital about 3 years ago and that our own residents participate in. So some of you are familiar with Schwartz rounds. It's fairly popular across the country, but it was named after Ken Schwartz. He was an attorney, a healthcare attorney who died of lung cancer in 1995 when he was 40. When he was sick, he posted an article in the Boston Globe, and he says in there that it was his caregivers, his compassionate nurses and doctors, who made the unbearable bearable. And he had this concern that where healthcare was heading in the 90s with managed care organizations, and HMOs and PPOs, that it was at risk. Healthcare was at risk of losing its compassion. So he had a dying wish to create a center that was dedicated to compassion. And so the Schwartz Center does just that. And one of the activities that Schwartz Center hosts are the Schwartz rounds. And I'll explain those to you in a minute. They were piloted at Mass Gen in Boston in 1997. And since then, they've expanded to over 550 hospital sites in the US and Canada, Australia, New Zealand, and the UK. So what do these look like? Now, this isn't a picture of my own hospital. These are Schwartz rounds at UCSF. And typically all seats are full, some standing room only at many hospitals. And what you have with Schwartz rounds is a planning committee. They decide on a theme or a case that we should be talking about and normalizing in medicine. And typically it might be a really difficult patient case that was emotionally difficult. You find 3 to 4 panelists, and the focus is on caregivers who tell their stories, the doctors, the nurses, the trainees, the techs. We've had our cafeteria and food staff. They've shared stories on our panels, EVS, right? The focus is on the people in the hospital caring for patients and their families and what it feels like to take care of patients. And so during rounds, the panelists share brief 3 to 5 minute stories of their experience, whether related to the case or the theme. And then after that, we open it up to the attendees, the people in the room. We want to hear from them, the colleagues that are in the room saying, thank you for sharing that. I had this experience with the patient, and I'm so glad you said that out loud because I had the same experience. These have worked really well at our institution, and I want to share some of the previous topics that we've talked about. We've talked about when everything you have is not enough, carrying through a pandemic, that idea of being totally out of control with the suffering that was happening all around them. Tragedy and triumph in transplant. We have a large transplant center here, what we can all learn from those difficult cases. Of course, the patient I'll never forget. We did the healer as patient when our doctors and nurses have gotten severely ill and become patients at our own hospital, and how transformative that was for them. We talk about when caring doesn't feel good, difficult days, difficult patients, when you don't even want to be here, right? And then the power of apology, vulnerability, and forgiveness in healthcare, when terrible mistakes are made, and what that feels like as a clinician, and what apologizing feels like, and the power of that. I do want you to remember that reflection doesn't have to be formal like it looks with Schwartz rounds. Being vulnerable and talking about the things that matter most that we often don't give voice to doesn't have to be a big production. With your own residents and your own programs, reflection can look like monthly sessions that you have with your residents where they get to talk and reflect. I've done this with our own internal medicine program. Family medicine does this often across the country because they have psychologists who work in the clinic who will also work with the residents in a group setting. And now our wellness director are running some of these reflective groups with our emergency medicine interns to talk about those experiences. So what does that look like? Replacing one noon conference a month or an hour of block conference once a month, and have one of these groups together. Could be led by one of your own faculty members who has an interest in this, or if you have a wellness director or a psychologist. And you can just use really approachable prompts with your residents. You can have them either write a reflection. I've had our residents do that before, and then share it if they feel comfortable, or just in discussion, in dialogue with each other. So some prompts that have worked well have been, looking back over the past month, what's one thing that happened that stands out to you the most, and why? Was it a beautiful thing? Was it a painful thing? Was it a hilarious thing? But let's talk about an experience that made you feel something and what that was like. Or what's the most memorable patient you've encountered recently, right? Reflection can look like normalizing debriefing after serious events. We do talk about that. Yes, we do debrief when there is a really troubling trauma or a code, but this is really important with our trainees. My medical students tell me consistently about their first code, doing chest compressions, watching someone die, and then no one talks to them about that, and you just go on to the next patient. It's really important for our students to see that it's okay to acknowledge how strange it is to have a patient who's alive one moment and dead the next, and being able to say that out loud. You can even have brief reflections at faculty meetings. Just spend a few minutes, 5 or 10 minutes at the beginning of a faculty meeting, and ask someone to share the most meaningful or even the most difficult thing that happened at work over the past few weeks, and to just start slowly giving voice to the fact that we are all so utterly human, and that your whole selves are being brought to work every day. And it's always more than just work. It's always more than just a job. I think ultimately we have to acknowledge suffering in medicine. It's everywhere. We have to acknowledge patient suffering, our own suffering, the suffering of our learners. Now, you're never going to fully know another person and what they've been through, but you can recognize suffering and loneliness and fear because you're human. So you can see it in your colleagues. You can see it in the people that you love. You can see it among your patients. And that's because you share that potential for suffering with everyone around you. When we're able to look at our own pain, we're just better able to be present for the pain of other people. and to care better as clinicians and as faculty. Right? I'll leave you with this quote from Arthur Frank, the medical sociologist, that I think captures what we've been talking about today. Human suffering becomes bearable when we share it. When we know that someone recognizes our pain, we can let go of it. The power of recognition to reduce suffering cannot be explained, but it seems fundamental to our humanity. All in all, I think we need to make an effort to normalize the human experience of healthcare. Right? Doing so, it's going to make better clinicians, better residents, better students, better people. To be human is to be vulnerable. Clinicians share that with their patients, right? And acknowledging that we're all vulnerable to the capriciousness of this life, that at any moment we can be in a situation just like the patients in front of you. That's where compassion starts. And I think that's what will bring back that deep meaning to the work that you do and the reason why you decided to be in medicine in the first place. So I want to thank you again for inviting me to speak to you. If you're interested in any of the work that I've referenced and cited here, I have them listed. And I want to reiterate my gratitude for this opportunity. Thank you.